Good afternoon. Thank you for attending our ASC Cyto e-conference for today on the topic glandular lesions on cervical pap smears. It is my pleasure to introduce our speaker for today. Dr. Fang Fan is currently a clinical professor and director of cytopathology at City of Hope Medical Center in Duarte, California. Dr. Fan has more than 100 scholarly articles and several book chapters in the fields of cytopathology and breast pathology. She is the chief editor of Cytopathology Review, which is currently on its third edition. Dr. Fan is currently a member of the Scientific Program Committee of the American Society of Cytopathology and a newly elected member of the ASC Executive Board. She has given cytopathology educational lectures, microscopic sessions in the Oak Stone lecture series, Osler Cytopathology Board review courses, CAP annual meetings, ASC annual meetings, and USCAP annual meetings. So we are so privileged to have her as our speaker today. So take it away, Dr. Fan.
Thank you for the nice introduction. And so today we're going to talk about glandular lesions on cervical pap smears. Okay. Let's see how to get rid of that. Okay. Well, do a quick review of characteristic morphologic features of glandular lesions on pap smears, and briefly discuss about the management guideline, and then we'll do a few case presentations to see how we can learn from cytohistocorrelations. Sorry. And so this is just a brief outline of my presentation today. And pap smear in general is considered less effective in detecting glandular lesions, mostly due to sampling. And first of all, the conventional, the usual pap smear collection doesn't really collect endometrial cells, and so we'll have to wait until when the endometrial cells come to our slides during the collection process. And same with endocervical cells, that if it's really high up, the pap smear collection method won't reach it. Another is due to interpretation, because a lot of times the criteria are not well understood or well followed. So at least from our end, we'll do a review of what are the established criteria on these glandular lesions. So to understand, we'll start with cervix. To understand the cytology aspect of the glandular lesions, and it will be easier if we start to know the histologic counterpart. So this is the squamo-columnar junction. You see the squamous epithelium here, and the metaplastic squamous epithelium over the top, and the endocervical, the normal endocervical glands underneath. Then going further up, you'll see the surface is lined by endocervical mucosa, and the benign typical endocervical mucosa are columnar epithelial cells with abundant mucinous cytoplasm and basally located nuclei, and the same for the endocervical glands lining underneath. And so the typical endocervical benign lesions we see include metaplasia, like squamous metaplasia, tubal metaplasia, inflammatory lesions, and hyperplastic lesions, and polyp. So these are the commonly encountered benign lesions. So any of these, the cells, would easily or likely fall on our pap smear slides. And for example, this is the endocervical polyp, and this is squamous metaplasia we already shown and then showed, and this is microglandular hyperplasia. And then on the neoplastics end, we have AIS and endocervical adenocarcinoma. So in contrast to the squamous lesions, we have, L cell, H cell, mild dysplasia, severe dysplasia. The term glandular dysplasia is not used in endocervical lesions. So again, on histology, it's either benign or AIS, or invasive adenocarcinoma. So we don't have that dysplasia category. And so this is a picture of AIS, and you see the nice transition here. And this is actually exactly the criteria we will use in cytology to diagnose AIS. So elongation and enlargement of the nucleus, and the hyperchromasia of the nuclear chromatin, irregular nuclear membrane, and you notice there a nucleoli actually is inconspicuous. So prominent nucleoli is not actually a feature of AIS. So again, this is what the cytologic criteria will be based on, is on these histologic features. So that's AIS. And when it becomes invasive, so that invasive endocervical adenocarcinoma look just like adenocarcinoma elsewhere, and they form glandular structures, and the chromatin is vesicular, and they have prominent nucleoli, typically macronucleoli. So when it becomes adenocarcinoma, usually we can tell it's adenocarcinoma, but then the question is, if it's endocervical or endometrial or metastatic. So we'll talk about that as well. So come to the Bethesda system, and for endocervical cells. So typically, I like to say there are kind of like 4 tiers. We have atypical endocervical cells, NOS, or specify, and again, I will elaborate on that when we have cases. So we have atypical endocervical cells, NOS. We have atypical endocervical cells, favor neoplastic, then AIS, then endocervical adenocarcinoma, sort of 4 tiers. And so the benign conditions I just described in histology, hopefully most of them will be benign reactive ECC on PAP. But some may be, classified as atypical endocervical cells, NOS. And then the neoplastic lesions, it may be atypical endocervical cells, NOS, favor neoplastic, or AIS. So it can be all 3 tiers, total 4. There's endocervical adenocarcinoma. So it could be either of these. So AGUS, it's important to know the atypical endocervical cells should only be used when the atypia raises suspicion for AIS or adenocarcinoma, because we'll talk a little bit about management, because AGUS is not a very, it's not a light or mild call, you say AGUS, not like ASCUS. And so AGUS will lead to something. So it's very important to know the criteria and follow the criteria and not overuse the term AGUS. Normal endocervical cells are sheets of honeycomb cells, and if we cut on the side, it will show like columnar cells or pickets in a fence. So everybody's familiar with this flat sheet arrangement, and a honeycomb, abundant cytoplasm, and corresponding to what we saw on the histology. So sometimes on the side you see kind of a nice lined up like a picket in a fence, looks mimicking our histologic pictures of benign endocervical cells, abundant mucinous cytoplasm, and a low NC ratio. And again, another large sheets of benign endocervical group. So here, compared to the last one, you notice there are increased NC ratio. So there are less cytoplasm now, and there is even a little bit crowding. But the cell overall is still have a round nucleus and a prominent nucleoli, and nuclear membrane overall is smooth and still have a flat sheet-like appearance. So this is reactive endocervical cells. And then another one, this becomes a little more, disorganized than the previous one, right? So it's a little crowded, and but overall the nuclei are round, and still more round than oval. that it's not elongated. And then we have nucleoli and vesicular, prominent nucleoli, vesicular chromatin. There are inflammatory cells on top of it. So this is still a reactive picture. And then another one, if you again catch on the side, you'll see this picture, columnar shaped, but with prominent nucleoli and still a good amount of cytoplasm. So that again is still ECC, reactive ECC. And this one, the cells look dark, crowded, and there's increased NC ratio, but here you have a nice terminal bar and with cilia here. That's tubal metaplasia corresponding to the tubal metaplasia. In histology here, again, in tubal metaplasia, the nuclear size typically will enlarge and become a little darker. It's important to recognize the terminal bar and the cilia on top. And so this is an important table. So when do we call reactive? When do we call atypical? And it's architecture and nuclear features. So architecture reactive, it's a flat sheet. When it's atypical, it's more crowded, three-dimensional. You may see microacinar structures, and on the edge you'll see feathery edges. And reactive ECC have well-defined cell borders, and atypical, the cell borders become indistinct. I bolded the two features because those two I feel is most important. And so reactive ECC again have round to oval nuclei. In atypical ECC, the nuclei become elongated, cigar-shaped, and they'll have irregular nuclear membrane and really dark, coarse dark chromatin. And again, atypical ECC have indistinct nucleoli, while reactive ECC usually have small prominent nucleoli. So prominent nucleoli is not a feature of atypical endocervical cells. So this is as a criteria listed in the Bethesda book on atypical endocervical cells NOS. So that's the first tier of atypical, right? So this basically just re-illustrated what I just listed in this table. So you have some crowding, some nuclear overlapping, you have some nuclear enlargement with mild hyperchromasia, and you have, with that it comes with increased NC ratio, but cell borders are still defined. And like we said briefly before, the common histologic findings corresponding to atypical endocervical cells NOS are actually benign. Cervicitis, atypical repair polyps, and other mostly are benign situations. So this, if you still remember the picture from previously, this one, the nuclei become more columnar, more elongated. It's not round, no longer that round anymore, and it's more crowded, and the cell border are not so distinct. It's more crowded, but still, they have this little nucleoli, and there may be a little acinar structure here. So there are some architecture atypia and some hyperchromasia to it, but overall, it's not too bad. So this can be put in atypical NOS category. And this, compared to the previous one, is even more atypical in that the chromatin is become more granular and it's more hyperchromasia. You don't always see that little nucleoli anymore, and it's much more higher NC ratio, so that you see the diminished cytoplasm, and again crowded, elongated, and hyperchromatic nuclei. So this is again still atypical endocervical cells, NOS. And another hyperchromatic crowded group is, cells look actually more round here, but on the periphery you can see, and some columnar cells. Again, there are actually some of it still have little nucleoli. So this is still atypical NOS. Then the next tier would be atypical endocervical cells favor neoplastic. So it's just everything more. So it's more cell crowding and the nuclear overlapping, more hyperchromasia, and you'll see more maybe rosetting or feathering even, and cell borders may be more defined. So here, you'll notice that it's again elongated, but this is much darker. It's more hyperchromatic, and it's more crowded. You may see little, little acinar structure, and much more disorganized, and that vesicular type of chromatin and the nucleoli are completely not here anymore. So this is definitely worrisome. And then this is when we say atypical endocervical cells favor neoplastic. And another one, and this is more, towards the pushing it. It's again very columnar cells, elongated cells with hyperchromatic nuclei and high NC ratio and very crowded structure. And you can imagine some maybe secondary acinar architecture here. So definitely atypical favor neoplastic. And another one showing similar, I mean, this is definitely kind of a glandular structure here with crowded and hyperchromatic groups with elongated nuclei. So just pause briefly here. And so this is reactive ECC. This is neoplastic ECC. This is when we call atypical endocervical cells favor neoplastic. And again, going over the criteria that architecturally this is more or less still a flat sheet. And here you can't say this is flat sheets anymore. They are crowded and they may have secondary architectures. And chromatin wise, this is overall still nuclear wise, and this is still more round, maybe a little oval. This is elongated, and that's it has a prominent nucleoli, and this is hyperchromatic and no nucleoli. So that's a picture to remember for your reactive ECC and atypical ECC. So then the next one would be AIS. So we said favor that. Then when do we push it for AIS? AIS is when you see their cells even falling off at the edges. That's called the feathering. And even more, it's just everything even more disorganized and crowded, and the cells falling off on the edge. And so that's AIS. And again, sometimes, it looks like a bird's tail. It's being used to describe AIS, that it's just, how crowded and hyperchromatic and elongated the nuclei are, and the secondary acinar structures. And so this is AIS. Sorry, yeah. So this is more AIS, again, showing similar things. And I think when it is at AIS stage, most people recognize it. It's more of in the beginning, like is this just a reactive ECC of it? We call it atypical endocervical cells, NOS. That's when we need to really follow good criteria. So, but again, we know that this is eventually, when we call atypical, is eventually the criteria is, this is like full blown criteria with hyperchromasia, elongation, cells falling off at the edge, very crowded groups. So that's AIS. And so the mimickers of atypical endocervical cells, or AIS, we briefly talked about tubal metaplasia. Again, the most important one is reactive reparative endocervical cells. Sometimes endometrial cells will be become part of the differential and squamous metaplasia. So again, this is a very crowded group, and the cells actually look more round. And if you look, and there are this terminal bar and the cilia at the periphery. So this is the tubal metaplasia compared to atypical endocervical cells. Let's say NOS category, the nuclei tend to be more round than oval, so it's not really that elongated, but it can be very hyperchromatic like this one, and you can definitely see some elongated cells in some examples. And so important thing is to see to identify the terminal bar and the cilia. And so again, like I said before, and so this it's important to not call everything atypical endocervical cells, NOS. This is a reactive repair picture when it's still a flat sheath. And there are some mildly irregular nuclear membrane and a variation in nuclear size and shape, but overall vesicular chromatin and small prominent nucleoli, vacuolated cytoplasm, and so the overall this is reactive and repair. And another picture of reactive ECC when, it's a good NC ratio, smooth nuclear membrane. This is more oval nuclei, but again, this is not called, this is not atypical endocervical cells. And this is endometrial cells. And endometrial cells, in general, they are three-dimensional because, if it takes endometrial cells all the way roll down to your slide, it's typically already three-dimensional clusters. So in that sense, it might cause suspicion for atypical endocervical cells because of the three-dimensional architecture. But if you look at the nuclei, they typically look degenerated. And on thin prep, they have this kind of a reddish hue, and they have very irregular nuclear membrane. The cells are smaller, and they don't have that elongated and well preserved nuclei as an atypical endocervical cells. So, but it's something to keep in mind, and that sometimes it may mimic atypical endocervical cells. And then CIS or AIS. CIS typically have a spectrum of squamous dysplasia in the background, and cells have a more round than columnar shape. But again, if you are at this differential, it doesn't really matter, just, because something needs to be done. And this is more for our academic purpose that, do we call this CIN3 HCl or call it an AGUS, favorite neoplastic or AIS. So do we call it HCl or AIS? I'll show an example later in situations where we cannot make that distinction. Okay, so that's let's see. Okay, so we have talked about atypical endocervical cells, NOS, favored neoplastic, and AIS. So the next is endocervical adenocarcinoma, so the last tier. So endocervical adenocarcinoma, again, then it will just look like an adenocarcinoma. And so it have three-dimensional groups. The cells are bigger, and they have enlarged pleomorphic nuclei. Typically, they'll have this granular cytoplasm, macronucleoli, and disorganized, and then cells are bigger, and so you can tell they are adenocarcinoma. So once it's in this level, it's actually not that hard, and it's maybe challenging to decide if this is endocervical adeno, endometrial adeno, or some other adeno. But in general, this is actually not a problem. And you'll see a necrotic tumor diathesis, like you see a little bit here and there. Again, some more pictures of endocervical adenocarcinoma, some tumor, but you feel like there are this granular, dirty background, and tumor cells are larger and have this macronucleoli and have this abundant sort of granular cytoplasm. And so this is in summary of the endocervical, atypical endocervical cells. So this is reactive. That's when we call it NOS. Again, NOS, most of them still on histology are benign. And then this is favored neoplastic, and then AIS. So you see how the architecture and the cytologic transition is doing here. So elongation, hyperchromasia, crowded, totally disorganized arrangement, and so that's again, it's important to not overcall atypical endocervical cells NOS, and because I will show you in the management, all AGUS diagnosis will lead to some kind of a management procedure clinically. Okay, so that's atypical endocervical cells. A few words about AIS. And typically they don't have symptoms at pre-invasive stage, and it's typically screening detected or during workup for cell lesions. And we know in WHO classification, AIS is divided into HPV associated or HPV independent. And of the AIS cases that are diagnosed by cytology, almost 99% are HPV associated, and most of them HPV-16 and or 18. The HPV-independent AIS are the typical gastric type differentiation. On morphology, they are similar to HPV-associated AIS, and there was one paper talking about the presence of yellow gastric type of mucin in better seen on conventional smears. I have not been able to tell, and again, that's not important because now, almost all PAPs you get a co-testing, the HPV status, and this is not something we need to really make that distinction on PAP. But to know there are HPV associated and HPV independent AIS. Same is true for endocervical adenocarcinoma, that you can have HPV associated and HPV independent. The typical HPV independent endocervical adenocarcinomas are gastric type, clear cell type, and the mesonephric type. Again, these subclassifications are made on histology. On PAP, if we know the HPV status, that's usually easy. But otherwise, the criteria so far, we don't really, use different criteria for HPV associated or non-HPV associated endocervical glandular lesion and neoplastic lesions. So now moving on to endometrium. And so this is a typical sort of a proliferative endometrium. You have the test tube-like, straight glands. And in endometrial lesions, we have it's even less. We have benign, we have malignant. The benign lesions typically we have polyp and endometrial hyperplasia with or without atypia, and the atypical endometrial hyperplasia is also called EIN, endometrial intraepithelial neoplasia, and then we have endometrial adenocarcinoma. And in PAP, it's just two tiers, not like atypical endocervical cells. You have NOS, flavor neoplastic, and AIS. But for endometrial cells, we'll have atypical endometrial cells, NOS, and or endometrial adenocarcinoma, just two tiers. And so just to remember that, and sometimes people get confused with the terminology. So, and typical endometrial cells, again, you come all the way down from the endometrial cavity, so automatically it's small, crowded, three-dimensional groups, and the cells typically look degenerated. The size of the nucleus is similar to the intermediate squamous cells, and they are round to irregular, look degenerated, and sometimes you'll see a double contour with, it's called exodus, with glandular epithelial cells on the outside and stroma on the inside, like this. So that's called exodus. And the difference between endocervical cells and endometrial cells are smaller, and it's more uniform, and it's oftentimes crowded and with scant cytoplasm. And people say endometrial cells, the nuclei vary in shape but not size. That's similar size as the intermediate squamous cells. And endocervical cells, the nuclei vary in size, not shape. They're round, but you can have a variation in size, but it's round and with smooth nuclear membrane. So, and this is a picture of endometrial cells, and endocervical cells are bigger. They have round nuclei with small nucleoli, and this is typically kind of degenerated, crowded, and much smaller appearance. So what are the criteria then for atypical endometrial cells? We know it's already, architecture-wise, it's already crowded, right? Nuclear membrane-wise, it's already irregular, and sometimes they have a little nucleoli. So what is the criteria then for atypical endometrial cells? And the endometrial cells, the key is actually the size. So again, they form three-dimensional little clusters, but the nuclei are enlarged compared to normal endometrial cells. They may have a little hyperchromasia and small nucleoli and EO-defined. I mean, they typically have EO-defined cell borders. So the criteria I would hang on is the increased nuclear size. And if you find an adjacent intermediate size squamous cell and compare, and it's enlarged. Otherwise, the architecture and other things are similar to the normal endometrial cells. This is another picture of atypical endometrial cells. The cell size are enlarged, they a little bit hyperchromatic, small nucleoli, and three-dimensional groups. And typically, a lot of times, it's the cytoplasmic vacuoles will have neutrophils associated with it. This is an atypical endometrial cells. This is, when you say atypical endometrial cells, NOS, or with a comment. This one is with a comment. Atypical, most likely associated with IUD use. This patient is known to have an IUD, and with this vacuolated, they can look really atypical, the endometrial cells. And you see the enlarged nuclear size. And sometimes you have to wait until they remove the IUD and then to follow up, because it's sometimes impossible to tell if this is adenocarcinoma or IUD effect. And so then the next step above atypical endometrial cells, NOS, is endometrial adenocarcinoma. Again, the cell size is even bigger. And again, typically these endometrial cells on PAP have this reddish hue. And they are even bigger, more enlarged and vacuolated cytoplasm. And typically, you'll have, I'll show you the next picture, you have intracytoplasmic neutrophils, and like this. And so it's typically enlarged. Again, this, when you see this on your PAP, you probably can say, oh, this is adenocarcinoma. And then the criteria separating endocervical adeno and endometrial adenocarcinoma are not entirely specific or reliable. And so I have even on histology, sometimes we have problem to tell if it's endocervical adeno or endometrial adeno, because it does change management, the surgery and the treatment. So, but we always try our best. For endocervical adenocarcinoma, typically you have more cells, and the cells are larger, and they have large multiple nucleoli, they have granular cytoplasm, and the endometrial cells are smaller, and they have less quantity on our PAPs, and they have vacuolated cytoplasm with polys. And if we have a cell block to do immunos, endometrial cells are typically, they are not associated with HPV, so they are P16 negative and ER positive. And endocervical adeno, again, you be aware, we also can have HPV negative, not associated endocervical adeno, but most of them are associated. So if we have positive P16 and negative ER and positive HPV, that's definitely favor endocervical. So this is endocervical adenocarcinoma on the left side. You have these macronucleoli, abundant sort of a granular cytoplasm, and cells are bigger. And on this right hand is endometrial adenocarcinoma. You have this vacuolated cytoplasm with a lot of neutrophils in the cytoplasm, and and the cells are just a bit smaller and nucleoli, and this usually typically have a macronucleoli. And again, when it's typical, it's easier, and when it's not sure, try to use ancillary studies if you have, or you may know the HPV status. So this is the summary picture for the endometrial cells. And so again, this is your normal benign endometrial cells. This is atypical, and this is the adenocarcinoma. So the cell size, become more enlarged, and it's a little more hyperchromatic and irregular, and with a nucleoli. And nucleoli becomes more obvious in the adenocarcinoma, and then also the normal endometrial cells don't have this cytoplasmic vacuoles, so you'll start to see them in atypical, then in endometrial adenocarcinoma. So this is again kind of a summary picture for the endometrial agas. And mimickers, so just use a couple of slides talk about mimickers of benign endometrial cells. So And so the benign mimics of benign endometrial cells, the most important one is H cell. So previously we did a study, and I think a lot of published study also a lot of time before when we did a lot of PAPs, that one reason of H cell being missed is because it was interpreted as benign endometrial cells on low power. And so all small dark cells, endometrial-like cell clusters deserve a high power examination. So like at this low power, you saw this, you said, oh, it's probably endometrial cells, and just let it go, and the background, the squame look all sort of okay. But if you go on high power, you actually, once you go on high power, it's not that hard to tell this is actually H cell. But low power, it might be get by as a benign, endometrial cells. So that's just something I wanted to point out. And so in that regards, that talking about differential diagnosis, one is benign endometrial cells, one is H cell here. And so obviously this is benign endometrial cells. They are smaller, they are more uniform, and they form these loose clusters and appear degenerated. And the H cells, and it's still a little bigger. The cytoplasm is dense, and the chromatin. Again, once you go on high power, you will be able to tell. It's the question is, don't just on the scanning power decide it's endometrial cells and not look further. This is AIS, or atypical endocervical cells, favor neoplastic. Again, low power, you may not, but once you go on high power, it looks very different from atypical endometrial cells because of the nuclear shape and the chromatin quality and all that. Okay, so then there are also atypical glandular cells. There are also atypical glandular cells, NOS, or atypical glandular cells favor neoplastic, and this is if the origin of the cells cannot be determined, the generic glandular term is used, and I will show you an example of when to use that. But usually we endocervical cells and endometrial cells do look very different, so we should be able to tell. But then when we cannot tell, we use a generic atypical glandular cells terminology. And again, still under the Bethesda glandular category, there are also endometrial cells present in a woman over or equal to 45 years of age. And it's optional to add this educational comment if you want, and the glandular cell status post hysterectomy. And the last one under glandular is the extrauterine adenocarcinoma. And the keywords here is malignant cells, clean background. And usually the morphology is unusual. When you look at the PAPs, you feel like these cells almost don't belong here, and it's clean background. So for with endocervical adeno, you have that tumor diathesis, sort of a granular background, and with endometrial adeno, you typically have a bloody background. So this is an example of metastatic adenocarcinoma. You see how there's very clean background, and then there are these three-dimensional tumor cells, almost look like not belong there. And this is metastatic ovarian carcinoma. So a few words about management of atypical glandular cells we talked about. So the interpretation is uncommon and poorly reproducible. There are quite a few studies done by the CAP and showing not so good inter-observer concordance. So that's why it's important we all follow the same criteria, stick to the criteria. That way we can be more reproducible. And it has been, like I talked about atypical endocervical cells being associated with benign conditions, polyps, metaplasia, neoplasia, and atypical endocervical cells a lot of times are associated with squamous intraepithelial lesions. Because endometrial cancer is not associated with HPV, reflex HPV is not recommended as a triaging for AGC. And so but I think next year the screening, the cervical cancer screening may transition to primary HPV screening. So we'll see how that's going to change the glandular lesions. So this is still the current management guideline, just to show you why it's important to follow the Agas criteria and not call Agas so easily. So if we call something atypical endometrial cells, and again, using the good criteria, then they'll do endometrial and endocervical sampling. So it leads to immediate, invasive procedures. And all other subcategories, they will do colposcopy and endometrial sampling depending on patient's age or clinical risk. And then you say, okay, so why do we, for the atypical endocervical cells, why did we have to do all that tiers, NOS, favored neoplastic, AIS? This is because of this next step. So if your initial cytology is NOS, or atypical endocervical cells NOS, or if the initial is favored neoplastic or AIS, so knowing this, we don't, in reality, we don't need to struggle, is this favored neoplastic or is it AIS, because that is managed the same, but we do need to separate out NOS. So if it's NOS, it goes to this pathway, and if it's favored neoplastic or AIS, that will lead to diagnostic excisional procedures. So again, just to tell you how important it is to follow the criteria and to put the atypical cells in the corrected category, because there are clinical management consequences. So with that, we'll just quickly go over 3 cases. Case number 1 is a 30-year-old woman, routine PAP, and we see this large glandular group. And I say glandular group because you see these are round cells with round nuclei, prominent nucleoli. I mean, they look like endocervical cells, and look like a reactive endocervical cells. It's just a bit crowded and really don't fit what we just talked about, atypical endocervical criteria, right? Atypical endocervical cells should have more elongated and hyperchromatic, nuclei. And this patient appears to have quite a bit of this large, this is more sort of a flat sheet. And instead of, although it's a little disorganized, but it's overall flat sheet. And going back to that, and if you, again, whenever you see this group, always look at the periphery, and you see there's terminal bars and there are cilia, terminal bars and cilia. And so this is more or less flat sheet. And then we found another group of really columnar and really nice terminal bar and cilia. So this another group, and using different, you can focus up and down, you can see terminal bar and cilia. So really we should have just called it benign, reactive endocervical cells, or this is when you can say atypical endocervical cells. Remember, you say NOS or make a comment. You can say we should have said atypical endocervical cell most likely associated with tubal metaplasia. Then they probably can just wait and not really do anything. But I think the pathologist was really still worried, and went ahead, called it atypical endocervical cells, NOS. Again, retrospectively, it didn't really meet the NOS criteria. So of course, they did a follow-up cervical biopsy, and this is the biopsy. We see the squamous columnar junction here, and a lot of inflammation. And these are the cells we saw on our PAP, and again, showing you this tubal metaplasia, terminal bar and cilia, and the cells do look actually a little more elongated and darker here, but it's no question it's tubal metaplasia, again, a lot here. So the patient has a lot of inflammation, and so this is kind of a part of the reactive changes, and so eventually, it's the cervical biopsy is just chronic cervicitis and tubal metaplasia. And so case 1, the learning points is, again, always follow the criteria when evaluating glandular lesions. And elongating nuclei, hyperchromatic chromatin are the 2 most important features when we call something atypical endocervical cells. Don't overcall Agas. Watch for tubal metaplasia. Case 2 is a 57-year-old woman presents with vaginal bleeding and previous PEPs unknown. When you see this 57 vaginal bleeding, you are thinking, oh, postmenopausal bleeding, endometrial. And then this PEP is actually surprisingly clean, very clean, right? But we see these two groups, and as this power they do actually look like endometrial group, except the backgrounds for some reason is very clean. And so we saw these two groups as let's go on high power, and they actually don't quite look like the endometrial cells I showed earlier, and the atypical endometrial cells or even endometrial adeno, they don't quite look like that. And let me see. Yeah, this is a better one. So it clearly looks adenocarcinoma, and the chromatin, very irregular nuclear membrane, macronucleoli, and some cells sort of lined above there have actually targetoid mucin here, and another group cells look more or less. This one actually didn't form three-dimensional clusters. It's more like partially, discohesive, kind of sheets-like, and again, targetoid mucin in the cytoplasm there, and another one, sort of grow in a straight line. And so remember, it almost like this didn't really look like the endocervical adeno I just described, and cervical adeno typically have macronucleoli, granular cytoplasm, tumor diathesis, and the endometrial adeno, the nuclear membrane units irregular, have vacuolated cytoplasm, and it's not so abundant. So morphological features again, small cluster, loosely cohesive sheets, clean background, normal squamous cell. The HPV co-testing is negative. And so we asked more, is it says the patient has clinical history of breast cancer. So at the time, when we didn't know, we suspect because of the clean background and also the morphology didn't quite look like, it looks like it didn't belong there. So this is when we used it as a generic atypical glandular cell category. We said a favor neoplastic, and we said the findings are suspicious for metastatic carcinoma because the leftover of the vial was sent for HPV co-testing, so we didn't really have anything left to do a cell block and to do immunos. And and so again, this is when you use a generic atypical glandular cell category. So this is the follow-up biopsy, and you see the submucosal here. This is tumor cells, and you see this typical lobular carcinoma, single filing type of growth. And when we used to do a lot of breast FNAs, that targetoid mucin, targetoid cytoplasm mucin is also pretty characteristic of lobular carcinoma. I don't think it's specific, but it's usually point to that the cells looks more or less otherwise monomorphic. So this turned out to be a metastatic lobular carcinoma of the breast. And again, when the background is clean and the cells don't seem to belong there, think metastasis, ask for clinical history. So that's the second. The last case is a young woman, routine PEP, previous PEPs have been negative. And this one shows the cells here, and immediately we can tell they don't look good. So high NC ratio, and the tumor cells, the nuclei are more round, I would say, and cytoplasm looks kind of dense. And again, another hyperchromatic crowded groups. And so maybe it's a bit columnar here, but overall here is more round. And we looked in the background. I think it doesn't have much. Again, a very cohesive group here, and maybe columnar. And here it looks like atypical endocervical cells, at least favor neoplastic there. And again, we looked. This is definitely getting close to be AIS. Atypical endocervical cells favor neoplastic, again, elongated, hyperchromatic, and crowded nuclei. This is a table showing you atrophy, CIS or AIS. They are all hyperchromatic crowded groups. And when we say hyperchromatic crowded groups, they're either nothing or something really bad. It's never something in between. It's, ASCUS will never form HCGs. LCL will never give you HCGs. So it's either nothing or something really bad. And so it's important to tell benign HCG versus neoplastic HCG. And then, the atrophy typically still have a very orderly arrangement, but CIS and AIS, CIS is crowded and disorganized, and the chromatin is fine, and but CIS can be, fine to coarse and coarse, and atrophy background can be dirty, so you can have atrophic vaginitis type of, dirty background. So that doesn't really, and CIS typically, hopefully at least have a spectrum of squamous dysplasia. Again, architecture and the cytologic features are important. These typically have very smooth nuclear membrane, now are indistinct nucleoli, and nucleoli is not, just a feature here that can be used, but chromatin and nuclear membrane and architecture. So this one seem to have both features of glandular and CIS and AIS. So we called it HCL, and also said atypical and cervical cells favor neoplastic. And the follow-up biopsy, this is a squamous HCL here. And on another field, they have clearly, either is the CIS involving endocervical glands or AIS. And similar to what we saw on the PAP, there are some columnar cells. And so on histology, we can just throw a squamous marker and tell us if this is CIS involving glands or if this is indeed AIS. Again, those are the cells we saw. We saw, AIS type of glands cells. We also saw CIS, like these round cells with a more of a round morphology. So follow-up biopsy is CIS and AIS. So the third case is just telling you if the differential is between squamous and glandular neoplasia. This is, we don't need to stress too much about it, just do both. So that to make sure they'll do adequate sampling. So you make sure you do an agas there, so they'll sample high. So this, this concludes my talk. Again, it's important to follow established criteria when evaluating glandular lesions. These are the, criteria written in textbooks, and these are the ones, we follow, and be aware of the pitfalls and understand the clinical management guideline. So agas is something, don't call it lightly, because if we call it, it will lead to some clinical action. So that's it. Thank you very much for your attention.
Thank you so much for a great talk. I don't see any questions on the question box or the chat. I just have a question. We all find, at least in our group, it's always a challenge to look at these glandular lesions. And we get lucky if sometimes, we have the corresponding COTA, HPV testing, and that really helps us. As you have mentioned, they're often HPV associated if they're cervical. My question is, how often, like if we didn't have HPV testing in your practice, how often do you do, like you mentioned cell block and all the other immunos, how often does that help you in your practice?
Sorry. Yeah, no, that's an excellent question. And I think the cell block utilization in PAP is being recognized more now. And so we are here, a City of Hope is a cancer center. So our patient population is not a general sort of screening population. And so we don't have enough volume to do HPV testing in-house. So we do send it out to ARAP. And because of that, and I have had a couple of instances I'd actually need cell block. So sometimes we call them to send leftover back. And sometimes if we actually talked about, maybe we should just upfront keep some, so there is it's the best if we do HPV testing in-house. It's not used frequently, but it can be helpful. And so I have had a couple of situations I would really love to have a cell block. But I don't have a good solution to that. So right now we just call them and have them send the leftover vial back to us.
Okay, thank you. I think that's really good. Yeah, we get lucky. We do our HPV in
Mm,
house, but we don't often do the cell block though. But I thought it was interesting. But we're aware, like we could do this and that. But and
mhm.
sometimes we get lucky too. We get the corresponding biopsy or the curettage. So every now and then it makes our life easier. But other than that, I'm grateful for your talk. It's really good.
Yeah.
I don't see any more questions on the chat. So,
Okay,
okay.
that sounds good.
Thank you so much again. So, I
Sure. Thank you, everyone.
okay.